Hi, and welcome back to the Why-O-Myo podcast. This is Janine Stiene, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy.
Disclaimer: all content, details, as well as education shared on this podcast are the opinion of the speaker and are for informational purposes only. Please consult with a certified medical professional regarding any questions or concerns, as this podcast should not serve as a diagnosis or replace the information received from a healthcare provider. You're watching part 2 of a 2-part episode. If you missed part 1, be sure to check that out first. Here's a brief summary of what you may have missed in part 1.
When you have speech issues that are specific to myofunctional therapy, the issue is placement. So where the patient is placing their tongue to make that sound. If you're a parent listening to this, it's important to ask, and it's important to always ask. And knowledge is power. There'll be so many things that could potentially be what you're about to experience because it wasn't picked up soon enough. And I do go back to the fact that if you look at it and you are not sure, then bring the baby to the oral surgeon as soon as possible. The more the public becomes aware and the more they ask for these things, the more educated they will become and we will become. After you call the provider who does can actually perform the procedure, they should be recommending exercises for a few weeks before the procedure and exercises for a few weeks after the procedure. Now, you can go to a speech pathologist for this or a speech pathologist, myofunctional therapist for this. Now, it must be a myofunctional therapist. A tongue thrust therapist is not a myofunctional therapist. So you can ask that as a question too. Are you a tongue thrust therapist and proficient in tongue thrust therapy or myofunctional therapy? They're different. So you can either go to the speech pathologist, who's the myofunctional therapist, or the dental hygienist, who is the myofunctional therapist. Both can address these issues. I feel like hygiene may be a little further ahead of speech when it comes to making the recommendation that early, only because we don't see that age group, because obviously they're not talking, they're not making sounds yet or sounds with intent, and unless it's a feeding issue, which if it's breastfeeding a lot of times goes to the lactation consultant, but it's not a bad thing to see a speech therapist to address it or to do the exercises before and after, or the dental hygienist. Like I said, either one. So we go back to when can you identify tethered oral tissue or short frenum. So the first time someone can identify it is immediately following delivery or in the first few weeks or the first year. And oftentimes, remember, that's based on some symptoms and symptoms that that provider understands could be this. Okay? I don't want to have to, I feel like I'm beating a dead horse. I'm sorry. So if it's not infancy and it's the pediatrician, then it's not going to be until the child sees a pediatric dentist. And again, as long as they're cognizant of what it is and how to identify it, and if I have anything to do with it, hopefully I can get the message out to more and more people through the different podcasts and through the lecturing opportunities, so that more of the parents, more of the clinicians, and all providers who maybe listen to this I hope listen to this at some point, start to hear what I'm saying and maybe do their own research and pursue their own education and training so that they can be better equipped. And honestly, it will set them apart, just like it will set a clinician apart from others when you can treat certain disorders or you're more proficient at certain issues. So anyway, so it's just, yes. Okay, so I'm sorry, I'm going off a tangent, I keep losing my thought. So the next time after they see the pediatric dentist, and they do recommend that you see the pediatric dentist at 2, I believe. Or maybe it's 1. It was 2, now maybe it's 1, or the opposite, but most parents don't usually bring their child until 3, maybe 4. I even know a handful of parents that didn't bring them until they were registering for kindergarten and they were 5 or almost 5. So the ones that done at age group, now they're in that pediatric with the pediatric dentist from, depending if it was 1 or 2 on up, or they're not getting there until 5, then, or 4, no one except for the pediatrician who maybe didn't realize it at the time and was not sure how it would affect anything now, so they're not necessarily looking for it, which maybe it should be looked at by all professionals so that it isn't missed. I don't know. Maybe that's something that's recommended. I would love to see checking it when you're in your first days after you give birth and you go to the pediatrician and they give you something. Oh, they used to give us a handout, but it's probably a website or something now about what your child should be doing at that age, but more so something for them that looks at their frenum at different parts along that trajectory, especially during that first year, and talk about the symptoms, talk about what they should see. From a speech therapist, we want to talk about what they should see. Looking at the tongue, looking at the lips, and having a better knowledge of what a child should be doing with their tongue in order to thrive unless they're using compensatory strategies that are affecting and negatively impacting so many other things. So the pediatric dentist will have them up, through 18, and during that time, if necessary, they're going to be referred to the orthodontist. And if no one up until that point realized that this child has a tongue tie or a lip tie or both, then all of the symptoms or some of the symptoms that child has had since birth has persisted or manifested itself in another way. And now you're at the orthodontist because of a lack of early intervention to support the growth of the oral cavity and the space within the airway. So now we've created other problems by not addressing the problem immediately. So if you're a therapist working in school and a parent asks you if you know a myofunctional therapist, obviously there may be people in your area that are myofunctional therapists. I say obviously, it's not obvious. You may have people in your area that you know are myofunctional therapists. It wouldn't be a bad idea to reach out to them, build a reputation with them, build a referral basis. Now, I know if you work in school, you have to be really careful about making referrals. So when I worked in the schools, I would just give a list of different practices all over the area and just what towns they're in or whatever, and that they, who specializes in myofunctional therapy. And you can say something like, it would be great. I think it might be great if you explore the myofunctional therapy to help support these issues. Now, as a speech therapist, if this child is on your caseload and you don't know, and they're getting articulation therapy because they have a ton of artic issues or producing sounds, have issues producing sounds that is impacting how intelligible they are, and that is negatively impacting academic performance. So it means that articulation issue is impacting how they're reading, how they're spelling, if they're saying wabbit instead of rabbit and writing it that way. Those are times that you would have a child on your caseload that may have articulation issues, but may also have a lisp or a vocalic R. So in that case, the speech therapist would work on their sounds in school, speech therapists, and the myofunctional therapist would work on the distortions outside in myofunctional therapy. Now, when it comes to making this split and making differentiating, it really has everything to do with the sounds and what they're doing to them. Remember, myo is more about distortion or placement errors, where in articulation therapy, you're changing the sound completely to maybe another sound. Okay, so when you're a speech therapist and you have this kid on your caseload and you've been working forever on the R or their lisp or the placement of certain sounds, and they are not improving, or they are great in therapy, but then the second they get into the waiting room, in the hall or in the classroom, they go right back to saying it the way they were. They may not be cognizant of when they're saying it wrong. They may not even hear the difference. And that's not relating to a hearing loss. So in those cases, that's typically the patient that actually needs myofunctional therapy. And no matter what you do, no matter how long you work on it, if you just worry about what the sound that they're distorting, if you just work on that, you're never working on the core of the problem, and the core of the problem is swallowing. So, and it's not feeding, it's swallowing. So, and I can guarantee when you refer the child to the myofunctional therapist, there's going to be so many other areas that are going to be affected that nobody even knows yet. And none of them would really ever, fall over back onto the speech therapist, I don't think, in school. But you have to be mindful, but it's important that you know to make a recommendation. It's also important as a school speech pathologist or CPS therapist, speech therapist, CPSE, I should say, or EI therapist, is when you're cultivating your referral list, make sure you ask some of those questions that I was mentioning earlier, like, are you a myofunctional therapist or a tongue thrust therapist? What else are you treating, or what else do you do? What's your other profession? I don't know. Pretty much asking, like, are you a speech pathologist, myofunctional therapist? Are you a dental hygienist, myofunctional therapist? All of those pieces, because based on what I was saying earlier, you should note that and then when maybe even have different lists and make the suggestion. So you can suggest which provider would be best for that child based on what's going on. Even from the perspective of a body worker or a speech, a myofunctional therapist who's also working on primitive reflexes. Like there's so many different facets. And so that's your patient. As a parent, I hope you know, as a quick summary, what you're going to ask and what you're going to be looking for early on, and as early as possible, I should say. And there's one thing I probably should have shared from the beginning. If you want to determine if your child or if you're tongue-tied, and just so you know, as adults, we can still be tongue-tied. I had my tongue tie released. I had a mid-tongue tie, or I used to call it posterior. Now they call it mid-tongue, or I don't know, the body of the tongue. I don't know. This is like all new to me. But the middle of my tongue, I have a tongue tie, what is a tongue tie? It's the little piece of skin when you put your tongue up and touch your teeth. It's the little piece of skin or membrane underneath your tongue. If you cannot lift your tongue tip up at all, or it's dimpled, or it looks like a heart, that is 100% a tongue tie. Once you see it, go get it worked out. Go see the oral surgeon, especially as early as you can, even as a baby. Your mid-tongue tie, or the tongue tie beneath the blade of your tongue, is not always easy to see and may not be easy to identify to a layperson, even to the myofunctional therapist. Sometimes it's not about what it looks like. Actually, most times it's not about what it looks like. It's about the issues that are presenting or things that you've witnessed. But that tongue, the skin or that membrane underneath your tongue, but more towards the underneath and the middle part of your tongue, it's often not easily identified. You could have the patient click their tongue, so they suction their tongue up to the top of their mouth. Sometimes you can see it then. Other times, if you just sweep your finger under their tongue and you feel any resistance, that could be an indicator. But like I said, a lot of times that one is not as easy to identify. But if you're having some of the feeding issues or articulation issues that we were talking about, then that may be the case. A shortened frenum on your lip would be your labial frenum. If you take your lip or the child's lip and you flip it upward, you want to look and see if it starts to blanch or turn white. If there's any membrane that looks as if it's or is splitting your two front teeth. And if that's the case, it's not always necessary, but especially if you're have a child that already has a lingual tie, because it's not uncommon to have more than one, then asking or looking or being suspicious of the lip tie is completely normal, and it would be okay to go see and just ask if it's an issue. But for the non-lay person, it would have a lot to do, if it's the pediatrician or the dentist or the orthodontist, it would have a lot to do with their symptoms, or a lot to do with symptoms that have been attempted to be treated but continued to relapse. So And the buccal ties, again, I feel like to the layperson, it would not be easy to see. Sometimes it's even hard for us to see. So often I feel those are picked up as part of one of the other ties, often not independently you're not independently being sent for buccal ties. But I could be wrong. I'm just saying based on my experience, just being able to look at it and identify it could really help as well. I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.